So if I could invite all the panelists from this session to pop their cameras back on. And Tony, if you're able to as well, I think there may be a question here for you too. So let's start with that point that Zoe picked up about familiarization. During the pandemic, people became familiar with technologies and then wanted to incorporate it more into their everyday lives and into healthcare services too. Can I invite you all for some comments on that point?
I could start.
Thank you.
Especially in my country, it seems that it was something that we weren't used to do. So yes, think that it's something that it can work under specific conditions. It definitely opened a new challenge and a new opportunity. Actually, nowadays in Greece, which is the place that you know that there are many remote islands and remote villages in mountainous areas, it will be of great use to have a national network of telemedicine. And it is true that the Ministry of Health is actually working towards that end. Actually, it was announced that during the running year, things will start really moving. It's under construction. And by the end of 2025, we will have a working national network of telemedicine. Seeing again that the pandemic has accelerated change.
Thank you. And Mark, that's something you've got, isn't it? A national network. Do you want to chip in?
Yeah, so basically that's been key to our, I think, uptake and adoption has been that national driver, that direction from above, leadership. It takes strong leadership, it takes commitment, but that national platform, that one platform that everyone uses, and having local champions and local people linking into services on the ground has made a massive difference as well. And I suppose one of our biggest learnings was peer sharing. So if you've got early adopters, getting them to talk to their colleagues, because we as leaders can talk about this, but if a consultant pediatrician's talking to other consultant pediatricians, it just lands differently. And I suppose some reflections from our COVID journey was that people fed back to us that having the choice of video actually improved their access. And when services started going back to in person, they were like, well, I've lost that choice now and I can't access my service as well as I could in the pandemic. So we had people that were like, this has made such a difference to me, even though we were in a pandemic and life was awful, but I could access my services far better by video. And people were complaining when GP practices were saying, well, we're not stopping video now because the pandemic's over. And people were like, no, please keep it. So, it's one of those unintended things you didn't think were going to happen, and it does. But sustaining it's a challenge, And I think clear communications from governments and from health leaders around what the public should expect and what the clinicians should be expected to offer is key as well. I'll stop there.
Thank you. Ulrich, do you have any comments?
Yeah, I can only second what has been said already, and just relying on what I presented before, I think it's very, very key to have a close focus on the practice level and implementation there. And I did another study on the Danish use of video consultation, exploring the patient characteristics. We didn't publish this in that study, but what we discovered was basically that a core group of GPs that were like the high users remained high users over time. So it seems to be so that for some, it added value. Maybe they had like an individual benefit, or the practice itself seemed to add from offering video, like Mark said, in addition to something existing, because it actually proved valuable to them, providing more flexibility, were meaningful for their workloads and how to organize care. But I think we need to be more granular. There's not like a one size fits all. You remember my Amaris Law curve before. So we need to be curious what's going on the practice level. And I completely agree with Mark here. This is where the digital champions maybe need to share some of their learnings and insights, because it doesn't seem to work if it's coming too much from top down. We need to look at maybe the meso level between the practices as well.
Thank you. And Tony, do you have any comments on this?
Yes, I have, and endorsing what Ulrich has said. So in the experience looking at and traveling and seeing many practices all over many countries. So one of the things that is very, very common is that the practitioners say, we've already used telephone as a means of communication with the patients, you know, and sometimes it's even worse to use the screen. So unless in some countries, what they do is they use WhatsApps, for example, but then there is the issue of, is this a proper consultation? Am I reimbursed for this? This is another concept that it's spread around. Am I reimbursed for a consultation, a video consultation, or a WhatsApp consultation, a telephone consultation, things like that? So this is something that is normal practice in many countries. And it happens either in urban or rural areas. It doesn't matter. There is no difference. And this is something that I think is worth exploring, you know, what's behind a video consultation, not just the act, the interface that you use, but at the same time, all the legal, financial requirements or what's linked to that. And at the same time, if a video consultation, maybe in the future, it will be automated, the information is included automatically in the electronic health record, because otherwise, so it's duplication of things. But this is not a rocket science, just to include this information that's done verbally, you know, to be recorded into the electronic health records. But there are many opportunities to expand that. Over from my side.
Thank you. That is a brilliant segue into the next question, which is about the use of AI, which is sometimes used now to capture telephone and video consultation and put it into text. So the question here is, with the recent AI boom in facilitating work overload in primary care, it might be easier if we start using an AI-enabled software for scribes and appointment scheduling to take away the administrative overload that detracts from patient care. Is there anything like this already in the works? Are any of you able to comment on that, where AI might already be used in primary healthcare? Ulrich?
This is something that we are exploring in Denmark at the moment. Some of my colleagues in Aalborg, a bit north from Aarhus, where I'm situated, have published some papers on the potentials for applying AI in relieving admin burdens. But yeah, it's there's still I think room for implementation studies. As with much technology work, you know, there's so much. Yeah, there are thousands of models being developed, but hardly anyone implemented. But I've seen some promising results there, and as with always technology, like if we understand what's important at the practice level, if we understand what's, like Trish mentioned before, like what's relevant for the people going to work with this technology, and in this case, if GPs could be invited into how to develop this, so that it's actually meaningful from the practice perspective, yes, then I think there are some maturity in utilizing this technology. But yeah, it has been done in other contexts, but we've seen examples maybe from the UK as well, you know, where it just leads to, you know, more contacts. But of course, you have some other issues here with staff and how that whole organization of care has developed over time.
I'll chat socio-technical around Europe. Have you seen any healthcare systems that are already integrating AI?
Are you asking to me, Rebecca? I couldn't hear your question.
I am, yes. Okay. On your travels around Europe, have you seen anybody actually integrating AI into primary care?
To be honest and sincere, I haven't been a big explosion of AI. Just what people do, and in consultations, the practitioners, they use AI just to confirm some diagnosis and things like that. But I haven't seen a platform that interacts directly with the practitioners in this case, just to make decisions. You know, this is because I understand that in the future AI will be a great contributor to the decision making, you know, But at the same time, maybe we'll see that the patients are very well informed because they'll go with an AI list of things that they'll do their self-diagnosis and things like that. And that's something that we have to take into account as well. So how to put a balance of what AI is and to put into the context and other examinations that you have to take into account. So not just mixing a few data, a few metrics that you've got around. So and this is something that it has to evolve. So to be short, I haven't seen any platform that interacts directly with that, unless somebody else in the discussion knows about it. I see that there is somebody sending a message here. Over from my side.
Thank you. Yes, we've got a message saying in WONCA 2023, doctors from the Netherlands showed their AI enhanced triage model called West Doctors. And I'm aware that some out-of-hours providers in the UK have started using it in relation to pick out key points from a telephone consultation. So early days. I'd just give a plug though that Ulrich's colleagues from Aarhus and myself are putting together a grant bid for a multi-centre European collaboration looking at exactly this issue. So if anybody's interested, please get in touch. Tony, while I've got you there, we've got a question. I've just lost it actually, about where has it gone? It was about the capturing of primary care data. What is the common terminology service that's used to record primary care encounters? Is it ICPC3? Tony, do you know anything about that? ICPC3.
Yeah, you mean the classification, the coding classifications. This varies in most of the countries. So some countries use ICPC 2 or 3. So at primary healthcare level, some others they use the International Classification of Diseases, normally 10. Very few countries they still use the number 11 that incorporates the ICPC. So this is a shame. When we try to assess governments, what we see is that hospitals and primary healthcare sometimes they don't have the same classification. Even they don't have, and I said that in my talk, the same identification of the patient. So hospitals have their identification, primary healthcare their own one, and then even the codification they don't link. This is something that there should be a big effort in countries to have an internal discussion. What's better if using ICD-10 or 11 and ICPC, and how do they merge? But I wouldn't like to just limit it to those two classifications. I would like to include as well the nursing classification, so the NANDA and NOC and NIC. So this is important because primary healthcare is more than GPs, and this is something, and it's important to have a consensus. That's why WHO started maybe more than 10 years ago to develop the ICPC 11, ICD-11, so International Classification of Disease number 11, that had a big consensus with SNOMED and with the ICPC, the International Classification of Primary Care from WONCA. So, and this is a big discussion, but each country is doing differently. This is amazing, but I think we should reach to a consensus on that.
Thank you. Thank you. And now a question about health professional or patient stigma or hesitation in accessing or providing digital primary care. Panelists, have you got any comment on this? So health professional hesitation in providing digital primary care, or patient stigma or hesitation to use services that way? Mark, I know in Scotland, this is something that you've worked to overcome with your peer networks. Is there anything else you'd like to?
Yeah, I think some of the drift back to in-person hasn't been driven by patient choice. It's been by clinician preference. And as a clinician, you know, we like being with people. It's part of what we enjoy about our job. So it does feel different interacting with patients remotely and digitally. But I suppose we are quite good at making assumptions about the kinds of patients that will or won't or don't want to use digital. And I think we really need to, you know, put that to one side and say to let the patient decide what works best for them. But we often make assumptions about old folk, people with disabilities, people with sensory impairments. And until we've actually had a conversation with them and asked them what works best for you, we shouldn't really make any assumptions about, you know, what's the best tool.
Thanks. Zoe, have you got any comments here?
Yeah, I totally agree with Mark. We shouldn't make assumptions. We should have choices. And I love the comment that Teresa made earlier about hybrid provision. We should have the choices and see what's more available, what's more appropriate for our patients.
Thank you. Ulrich, anything to add?
Yeah, I guess this is still like the chicken the egg paradox. Like, so I'm really curious about this myself, exploring video consultation. Like, what's driving this? And it's probably both. But yeah, there's some studies, of course, claiming that it's patient demand driving this way of offering video consultations. Others claim that it's actually mainly driven by the doctors or even the practice culture. And the truth is somewhere in between, probably. So it's not clear cut, and that's why we need to understand at the local level what's going on. I believe that in some places and cases it is GP driven, especially for the high users, and then they cultivate this as a proper access, one of many, as we've heard. While in other contexts, it might be driven by need and not perceived well by if there's like a lack of GPs or especially in remote areas. But yeah, I think it's linked to many things, as we've heard today, like literacy, but also like occupational values. Like we have had colleagues in Denmark exploring this. So again, yeah, it's technology embedded in like a practice with people. So we need to get a bigger picture, I would say, to understand this better.
Thank you.